just now, Dr. Ahire said, ki you do whatever in hand, they are going to land up in stiffness. But yes, but if we follow some good splinting, so we had a very interesting plaster session in the morning. Dr. Karkhanis had showed excellent techniques. So we'll just go through. First, I will just tell what not to be done. So this is usually seen like strapping of fingers, and we should avoid this dynaplast. Furthermore, these are the things which are done, and this is that sort of frog splint, what they call, the third one. I mean, whatever you write for the chemist, they give this frog splint, and that has been applied, and we can see that there is some injury because of that splint. Now this is that ball and ball splint. Again, this should be avoided. Another ball splint. This is sort of wrong immobilization. So in the morning we had a great discussion about that. So the wrist is in flexion, then MP joints are in extension. So this will lead to very, very poor results and a lot of stiffness. Another splint, this thing is always available, so this has been applied. The problem with this is it blocks the metacarpophalangeal joint and even blocks the IP joint. So better to avoid, and then the amount of pressure applied at this part, there is no control, and we should avoid this kind of splints. Always try and give elevation. So the famous cuff and collar is this button should go to this collar. So that is what is cuff and collar. So that is our resident, and this is we should always avoid that kind of position, and the injury should be at the heart level. If at all we are strapping, this is the best way to strap. We keep the IP the joints free so that they can do the movements. Commercially available. Now these are the conditions, like if there is scissoring, there is pseudo-clawing, there is angulation, there is shortening, better surgery. So splints, either they are static, dynamic or hybrid. They are used in all these conditions, like for fracture, corrective, supportive, protective, etc. This is an aluminum splint. It can be used as an outrigger or a cock-up splint. So a simple aluminum, and then we have those buttons, and we use it in this way, this fashion. So we can apply in this way. So this is like we are mobilizing, and that may not give lot of stiffness. This is the small IV, this is the suction tube which are used. So these are very cost-effective things which I am showing. So again, a dynamic splint with the help of aluminum splint. So here the MP joint is flexed, the PIP joint is extended, and then there is a rubber band which is attached so that they can do some dynamic movements. Same thing, if we attach it along the forearm within the tolerance of patient, and half minute to 3 minutes every hour. That is what is been advised, so that they will not get stiffness. We can even use this rubber band, the gloves, and the part of gloves. Again, this very, very simple techniques. I mean, we don't go for those fancy splints available. So these are again some rubber bands, some pins, and we ask for dynamic movements. This is readily available at every house. So we can use this also for mobilizing. Gloves, a part of gloves is cut and then it is used again to mobilize. Now some splints, this is a cock-up splint, routinely used. A short thumb spica, like for CMC arthritis, we use this. Dynamic wrist extension splint. static anti-claw deformity splint. So, and for the median and ulnar nerve, this is the kind of splint what we use. This is another very good splint, Kapner splint. It is used for PIP mobilization, and it is used in flexion contractures, PIP dislocations, volar plate injury. A very, very nice splint. This is a Zimmer splint. These are used for PIP fracture dislocations. I'll show it in detail at the later part. Mallet finger. So again, aluminum splint with the rubber cushion, and we try to keep the uh, distal interphalangeal joint in hyperextension and try to keep this PIP joint free so that they can do the PIP movements like this. So this is the way we apply commercially available mallet splint. This is another interesting splint called J splint. So if there is an open fingertip injury, so we do with a fracture at the distal phalanx, so we do the dressings and then we want to immobilize. So that this is a kind of J splint in which the PIP joint we can do the mobilization. So we have applied a dressing and then that J splint is been applied. So this is the way we apply the J splint, and so that the PIP joint remains free and we can mobilize the PIP joint. Outrigger splint, again aluminum splint with a cushion and with the wrist in slight extension. So again, the distal palmar crease, it has to be free whenever we apply all these kind of splints. So an outrigger splint, we put a plaster slab over the splint, and this is the thing which I want to highlight. So whenever we use a slab, so this is the central ridge. This ridge makes the slab stronger twice. So if we use like eight layers of plaster for a slab, if we make a central ridge, we make it 16 layers. So it becomes stronger. So whenever I apply a slab of a POP, I always make it a point that we make the ridge so that it doesn't loosen up and it becomes strong enough. So this is a short arm splint. Ulnar gutter splint. So again, this is applied on the ulnar side. See the position of the hand. So there is extension at the wrist. There is complete flexion at the MP joint, and IP joints are free. And so this one slab is applied over this side, and the other slab is applied on the volar side at the distal crease. So the MP joints are free. Thumb spica, again almost same. We apply in this fashion. Now there is always a debate: should it be a below elbow and above elbow slab, above elbow cast? So this is another type of splint, sugar tongue splint, where the elbow is also immobilized. So it starts from the distal palmar crease, round up to the elbow, and then come along to this part. Now, PIP joint injuries. Again, a casual approach is seen, like it's nothing, don't worry. And these are the X-rays which are done, AP and oblique. But what is required is a lateral X-ray. So there are many treatment options. So the number 1 and number 4 we usually do. So this is an extension block splinting like this for a PIP joint. Again, aluminum splint is used for the PIP joint fracture. Now this is a Zimmer static traction splint. So this is a case where there is a V sign positive, there is a fracture dislocation of PIP joint, and it is been managed with an aluminum splint with a static nail traction done under local anesthesia, what Dr. Ahia is going to speak about. And this is the kind of splint what we apply. So the aluminum splint is turned, or it is molded in a way like this, and we use a nail traction with a suture, and this is what has been applied. So there is a good reduction, the fracture is reduced, the dislocation is reduced, and we keep it for 3 weeks, that is a static traction for 3 weeks, and later on we give this kind of splint, and these are the results. So no, today morning also we had discussion on this. This is a position of safe immobilization. This is Dr. Paul Brand from CMC Vellore. So there is an interesting story about him. He was delivering a lecture, maybe of 1 hour, and throughout lecture he was keeping his hand like this. So once he finished his lecture, somebody asked, why are you keeping a hand like this? So he said, even if you don't understand anything of my lecture, if you just remember that the hand position should be like this, that's enough for me. So this is Dr. Paul Brand. This is intrinsic plus position. So 70 degree or 90 degree of flexion of metacarpophalangeal joint, full extension of IP, and slight extension at the wrist joint. This is the workshop where we prepare all these splints, and thank you very much.